So once you detect an air leak, what are the options? So we have the option to monitor closely. If it's a asymptomatic baby you incidentally found out, or a baby with monitoring, you have the transitional unit, baby has come after delivery and you incidentally find a pneumothorax. Baby has some distress but not too severe. So minimal support, you can use non-invasive ventilation in these babies if you would start it. Otherwise, if the baby has recession, we always discuss that start NIV. Don't go to high settings, but start with high flow or CPAP. And if the baby is tolerating, you just monitor them and wean off as you would. Consider a repeat X-ray to see the trend of the pneumothorax. And if the baby has respiratory distress, which is increasing, and you think the pneumothorax is contributing to it, then you consider treating it. So treating it now, the approach is changing. We are doing more of needling and less of chest drains. And we will be discussing how we do the needling next. So needling is needle drainage of the air leak, and catheter drainage is if you put a chest drain like she did, either you do it yourself or you have the pediatric surgeon coming and doing it. Sometimes we put a needle, and if it keeps accumulating, or if the baby has positive pressure ventilation, you put a chest drain after that. And if the baby is on invasive ventilation, you are more likely to need a chest drain because there is positive pressure driving air into the chest. So if there is an air leak, you are more likely. So you may still start with needling, but if it accumulates, you have a lower threshold to put the chest drain. If a baby who is on non-invasive ventilation develops an air leak, but otherwise doesn't need to be intubated, you can treat the pneumothorax first and see if the baby stabilizes. You don't need to intubate them just because you have an air leak. So again, that's another change from when I used to train. When I was training, if a baby has an air leak, first we intubate them. But the air leak heals better if they are not getting the positive pressure ventilation. So if the baby stabilizes and responds well to your drainage, the chances of reaccumulation is less if you have non-invasive ventilation. The same with meconium aspiration. We used to always intubate them before, but now we manage them more with non-invasive as well. So approaches are evolving. And as Dr. Karthik said, in the early 90s, we used to be very aggressive with management. Our confidence with non-invasive ventilation has increased so much now that almost any baby, provided the effort is good, any baby can be managed with non-invasive unless it's really severe. And the underlying diagnosis, air leak, meconium aspiration, PPHN, doesn't matter. So as long as the baby has the effort and the baby is stable enough. But if baby is unstable, you're having shock, you have other parameters worsening despite non-invasive, you have to be intervening in a timely fashion. You don't want to delay your intervention. So these are key messages, that constant monitoring. You are in intensive care. So you're not going to leave it that this baby is on this setting, I'll come back after 6 hours to see. It can change within a minute. And that's the importance of training the nursing staff, that you educate them. You make sure they understand that things can evolve and they should immediately bring it up. They don't hold back concerns. I mean, don't be shouting at the nurses, because if they are scared of you, they are less likely to come to you immediately. Encourage them. I mean, Dr. Narasimha was discussing teaching the nurses. So you teach them regularly so they feel close to you and they know that they can ask you questions. I mean, they don't feel that any question is silly. So same happens to all of us. I mean, not everyone knows everything at all times. I mean, I get so many questions I can't answer. I have to refer and tell. So it's the same thing. You know more than others, but doesn't mean you know everything. And the same applies within the team. A certain person is strong in a certain subject, but the other one is better. You need to acknowledge strengths and don't hesitate. I mean, not knowing is not a weakness. Acknowledging that you don't know is a strength. So that's an important concept you need to bring to your team. So spontaneous pneumothorax happens because of the initial negative pressure that the baby takes, and that is fairly common. About 1% of the population may have if you do population-based studies, but it's not ethical to do X-rays in well babies. So from the 70s, I don't think anyone has repeated it. There was some descriptive studies in Australia, and around 1% can have spontaneous pneumothorax, but most of these babies are asymptomatic. If you look at all NICU admissions or observations for TTN, if you're doing X-rays, you may find a reasonable number have a sliver of air or a pneumomediastinum, which doesn't cause any problem. So pneumomediastinum is air in the mediastinal area. If it is isolated pneumomediastinum, you have a higher risk of pneumothorax, but if the baby is asymptomatic, you just monitor them. You manage the distress as it needs, like a routine baby. Avoid excessively high pressures on non-invasive ventilation if you have a pneumothorax. Be careful with feeding such babies. You may prefer to keep them on tube feeds. Any baby with respiratory distress, I prefer 2-hourly tube feeds, not 3-hourly. You don't want to have an excessive volume with the risk of reflux. And again, you can have the thymus, the sail sign with the pneumomediastinum as well. Pneumopericardium is very dangerous and it can be life-threatening. All of us might have faced 1 or 2 cases in your career, and we have lost babies from that as well if you don't intervene. If a baby doesn't respond to CPR, we often find this as a pneumothorax happens and then they develop a pneumopericardium, they go into arrest or pulseless electrical activity. So this is one situation where even if you're not privileged, you may have to do it. And you should be aware of how to direct the needle. The Venflon can be used, and subcostal space direct it towards the left shoulder, slightly pointing upwards. So be having a underwater seal or a 3-way tap connected, and you drain there. Same can happen with TP and related pericardial effusion as well if it leaks. So pneumopericardium is not common, but if a baby is acutely collapsing, you have to think in your mind. And many resuscitation scenarios fail because of a pneumopericardium happening on top of it. We discussed pulmonary interstitial emphysema already. So we have a very difficult pathology underlying already. You have a ground for poor prognosis like lack of antiviral steroids or infection. And your treatment is not timely. You're exaggerating the non-invasive support or invasive support before you give surfactant. Then there is a setting for PAE, and PAE can lead to difficult ventilation. Your gas exchange is difficult and you have increased pressure use. Timely surfactant will help, but again, once a PAE happens, the surfactant may not make a huge difference because the interstitium is already leaking. And when you give surfactant, if the airway distance, the air leak may become more. So it's a difficult situation, and high frequency jet ventilation, if you have it, is an option, but we don't have it in most settings. High frequency ventilation is an option as well. You don't go to the lung recruitment strategy with the PAE. You don't recruit the lung in this setting. So PAE often leads to pneumothorax, and there is a high risk of BPD if a premature baby develops PAE. So once you have a PAE, you start talking of evolving BPD at the same time. So tension pneumothorax can be unilateral or bilateral, and when we call it tension, it means it's affecting the mediastinal pressure. So the cardiac function is affected, you get hypotension, you get difficulty with gas exchange. So that's what differentiates. We discussed the asymptomatic or mildly symptomatic pneumothorax. A tension pneumothorax is a medical emergency. There is a drop in blood pressure, acute desaturation with rise in ventilatory requirements. You can diagnose it with transillumination, which is the cold light we call it. And if the baby is collapsing, you can treat it on that basis. You don't need an X-ray to confirm. So needling or catheter drainage as the first step, because it's immediately available. It doesn't take time, but be prepared immediately when you're needling. Get someone to put the chest in, because a tension pneumothorax mostly won't respond to just needling, because the reason it became tension is because it's fast accumulating. And you may need to intubate and ventilate the baby because the CO2 is already high in these babies, and non-invasive ventilation may not be effective enough. Of course, chest drain will be inserted as well, and high frequency ventilation is a good option if you have it. So transillumination, basically you have the cold light on that side of the chest and it will appear. You compare with the other side. In a very small baby like extreme premature babies, the chest is already small and transilluminant, so you may not be able to differentiate that clearly. So you can see here that you have a pneumothorax on that side. It's a tension pneumothorax. The lung has collapsed. The mediastinum is fully shifted. So the needle thoracentesis, I mean, I prefer to use Venflon, the 18, 20 or 22 gauge. The 24 gauge is too small. It will get kinked off. And the advantage of using a Venflon is once you are in the chest, you can remove the needle. So once the pneumothorax expands, the butterfly needle can get a tear in the lung when the lung is expanding. And you cannot leave it in situ. I mean, if you want to observe for some time, you connect a 3-way tap. If it reaccumulates, so this is one way to avoid a chest drain. You have the Venflon in situ, you have to hold it down. And once the air is aspirated, you close the 3-way tap and keep it there. If it reaccumulates, you can drain it again. If it continues to reaccumulate, you will put a chest drain. But you cannot do that with the butterfly needle because the lung is opening back and the baby is moving. The lung has a shear. So the butterfly needle will tear the lung if you do that. So it's important that you know how to do it. I mean, you can have a three-way tap as you know how it works. So a three-way tap with the syringe connected is enough. You don't need an underwater seal. Once you insert it, immediately you'll get a burst of air. You remove the needle and connect the three-way tap. The chances of air going into the lung causing problems is limited. So you don't need to be scared of leaving it open for a brief second. It's not like a blood vessel where the air will suck and cause air embolism. This is a chest wall. And for the needling, you don't need local anesthetic usually. You just clean that area and put it quickly. So the site, usually we can do it in the mid-clavicular line or in the anterior axillary line. If you're doing it in the mid-clavicular line, which is usually preferred for the needling, second intercostal space in the mid-clavicular line, and upper border of the lower rib, you maintain that anatomical correlation because of the van structures being associated. And this is the site marked, and usually you abduct the shoulder. You need an assistant to abduct the shoulder, and then you do it here. Anterior axillary line also you can do if there is any fracture clavicle or anything affecting your handling the second intercostal space. So after you insert it, you have the the suction applied with the syringe, and you aspirate the air. You can repeat it till you get the air out. Make sure it's not too superficial, then you'll be sucking the air from the surface. So you will keep getting air, but it's not from the lung. So it should be in the pleural cavity. And the chest drain insertion, I mean, we have different options. We have the pigtail catheter, which many of us prefer to use because it's soft and coils up, but it needs a guide wire based introduction. So you need to be trained in that. You need to be comfortable handling it. It's a long coiled one, and when you insert the guide wire, you should be aseptic as well. Mostly blunt dissection is preferred to direct introduction of the trocar. I don't know how the pediatric surgeon did in your case, but on the left side, I have had cases where I worked before of the heart being punctured with the sudden burst. So always do a blunt dissection, and with an artery forceps, once the muscle has been punctured, you take the catheter. I'll show you in the next slide. So you have to hold it, and with the artery forceps, introduce it. You will be holding it in there and do it. And some of you may be familiar with the lack of chest drain. You use a ET tube as a chest drain. You can use a 2.5 ET tube as well. If you have an emergency, you use a blunt dissection. You initially make a small skin incision, use the artery forceps to blunt dissect. You need local anesthetic for the chest drain insertion. And possibly, if you're already intubated, give a fentanyl bolus because it's quite painful for the baby. And this is how you hold it, either a ET tube or the chest drain catheter. Don't use the needle that comes with it if possible. With the pigtail, I mean, it's not that dangerous because it comes covered with the cannula, so you can puncture and then take it out, reintroduce with the dilator. So then you secure it with a tie, and you can put a tegaderm to keep it secure. Make sure there is no tug on it because it can easily slip out. The way you can loop it up, put another tape so that the pull is not there and it doesn't come out. So this is the pigtail catheter if you have not seen it before. So this is a coil tube. The guide wire is inside. You have a dilator as well, through which the guide wire is inserted. The dilator, and then you thread the pigtail catheter on top of the guide wire, and then you take the guide wire out. The pigtail goes in like 4 centimeters, 3 to 4 centimeters. You have holes here up to the coiled part, and it straightens up. So it can stay without causing injury to the lung when it stays in because it's soft inside. It's the same material like a urinary catheter, the silastic. And you need the underwater seal. You have different adaptations. You may just have the bottle with the, like we had the bubble CPAP, the tube dipping into the water. You have it open on the other side if you don't have negative suction. If you want negative suction, you connect the suction catheter. So -5 to -15. -5 is adequate in most cases. Don't use excessive negative suction because that can lead to a bronchopleural fistula. So use negative suction only if it's not draining without the negative suction. So if it accumulates again, you start negative suction. If you use negative suction, start with the low pressure. -5 is enough in most of the cases. So don't use a high negative suction as possible. Remember that the higher negative suction, it keeps sucking the air and you may create a bronchopleural fistula or you may make it persist. The same with positive pressure ventilation. If there is a hole, the pressure, if you use higher pressures, you may keep it open. So extubating the baby is an option. If the baby is clinically stable, you don't need to keep the baby ventilated till the chest drain is out. That's another thing that's changed. So you can extubate the baby. So this is how it works. You have the underwater seal from the lung. This goes out. If you don't have the negative suction on, don't keep the suction catheter connected there because it needs to go out. The air needs to go out. So I've seen that mistake happening, that they connect the suction tube on it, but the suction is not on. You're turned off. So it should be open when you stop the suction. So remove that tube from the end of it. So that's an important thing that you should teach your staff, that if you don't have the suction on, don't keep the tube connected. You have to remove the suction tube. So the chest drain is connected to the underwater seal and -5 to -10. You stop the negative suction first if you have used it. Then you clamp the drain and then you remove it. So stages. The chest X-ray can be repeated a few hours after the clamping, but if the baby has increasing distress or you see the rising FaO2, you remove it quickly. You don't wait. And once we have stability, you remove the drain and you should be prepared to re-intervene. So if it reaccumulates, but hopefully you have timed it well with the planning stages and you don't need to reinsert. So I already explained that extubation may not be linked to this. If the baby is clinically unwell, needs eye support, you keep them intubated till you remove the chest drain. But if the baby is stable, you can extubate. And this might help you to remove the chest drain because the air leak heals quicker on an extubated baby. So again, it's a judgment call. It's not a dictum that you should extubate after the chest drain is removed. But if the baby is stable enough, you can extubate. No need to tie up the two. And no need to rush to remove the chest drain because if the chest drain stays 1 or 2 days, it affects kangaroo care and things, but it's acceptable to keep it as long as you take care of the infection control. We discussed in her case about cranial ultrasound, especially if the baby is premature, because there's a sudden increase in pressure, you may have a risk of IVH happening. And hearing assessment as well. If the baby had hypoxia or PPHN, you have to do the hearing assessment for that. And outcome is usually good unless you have other concerns. If the baby had asphyxia, baby had collapse or infection, then there is another scenario. Any questions on the air leak part? Take the mic if you have any questions. Please keep the mic to the... You have a mic. It's okay. We have one here. Turn it on. Any questions?
As you mentioned, in case of air leak also, we can go for non-invasive mode of ventilation.
Yes.
But then question is sedation, sir. If the baby is intubated, we generally completely sedate because we don't want baby to fight a lot. Because
I don't agree with that. Next is sedation. We'll discuss that.
Okay.
I don't sedate the babies just because they have an air leak.
Okay. But generally also in
We
ventilator,
will discuss sedation next. Yeah. Yes, Rishita.
Other thing we discussed is in non-invasive ventilations, if you give more pressures when the baby has an ICD in situ, there's a high chances of having a pneumothorax, continuous pneumothorax. But in what situations do you consider, suppose the baby has been term baby, ventilated for the pneumothorax, chest and in situ, 48 hours baby, 24 to 48 hours baby has been stable. You have deep extubated the baby had mild distress, so you put the baby on HFNC. You see that in 6 hours, in 4 to 6 hours, baby has deteriorated on HFNC. Then do you recommend the baby to go back to intubation or put on CPAP?
You can try CPAP or NIPPV. I mean, make sure you repeat an X-ray to make sure it's not the air that's reaccumulating. If you need air reaccumulation, you can connect negative suction for a period and manage. So sometimes there is pockets of air. You may need needling on top of the chest. So as I said, you need to be confident in your decision. Don't be passive. Be active in your thinking. Don't be negative in your approach. Be confident in the decision making. That's all. So I agree that it's not easy, especially in inexperienced hands. So sometimes we tend to act on the side of caution. But you keep doing that and you keep doing that for life. isn't it? So you need to make a sensible decision and you need to consider all the parameters. So you have to train yourself to think in a systematic way. So you have to put all the points to consider in the balance. Excessive sedation is something that makes you keep the baby intubated. Again, sedation itself causes side effects. We will discuss that as well. So sedation is not free of side effects. It makes your requirements more than less.